Good morning, everyone. I'm Dr. Subhakar, Consultant Critical Care from Care Hospitals, Bandara Hills, Hyderabad. So, I would like to take this opportunity to thank ISCCM Hyderabad chapter for the opportunity to participate in the National Nursing Conference. And my topic for today's discussion is ICU-acquired infections. So, hospital-acquired infections. So, not only add to the existing disease burden of the patient, but also contribute significantly to patient's morbidity, mortality, length of ICU stay, costs on the healthcare system, strain on the healthcare system, increased antimicrobial use, their resistance, prevalence of their resistance, and mortality also, as we discussed. So, healthcare associated infections, top four are urinary tract infection, pneumonias, bloodstream infections, skin and soft tissue infections. So, coming to the bloodstream infections and device use, 87% of the bloodstream infections are associated with device use. So, common devices used are CVC, arterial catheters, HD sheets, peritoneal dialysis catheters, and external fixators and pins used by orthopedics and other departments. So, what is a CA-BSI definition? So, any bacterium or fungi, that is bacteria or fungus, isolated or growth in a blood culture sample drawn peripherally without any other apparent source of infection. So, one of the following should be present. So, semi-quantitative or quantitative positive result where the same organism is isolated from the device, centrally inserted device, and peripherally drawn blood. Or if differential time to positivity is at least 2 hours or more between the centrally drawn blood, which will growth comes faster, 2 hours or more when compared to the peripheral. So simultaneous quantitative blood culture with a ratio of more than 5:1 with central higher quantitative growth when compared to the peripheral. 5:1 or more growth. That will constitute a CA-BSI, catheter-associated bloodstream infection. So, their catheter-related infections usually are local site infections like phlebitis, exit site infection, tunnel or pocketed infections, catheter colonizations, and bloodstream infection. So, extra microbial source of catheter-associated bloodstream infections are extraluminal colonization. So, extraluminal biofilm is a major source of CLA-BSI within the first week of catheterization in short-term catheters. And in long-term catheters, tunneled infection can form there extraluminally. Intraluminal, that is through the hub, contamination or improper usage of the hub, can cause intraluminal colonization, usually seen after 1 week. So epidemiology, common suspects are cons, gram-negative rod, staph aureus, and Prococcus candida species. So risk factors. So placement of central lines in unfavorable sites, that is highly contaminated sites, insertion with less than maximal precautions, heavy colonization, as I told you, contamination of the catheter hub, so improper usage of the catheter hub, CVC for more than 7 days, difficult insertion, unfavorable nursing ratio, established remote infections, or increased manipulations, TPN use, all those things pose a risk. So catheter line bundle. In general, catheter care bundles in general are groupings of best practice interventions grouped together. So 5 key interventions are hand hygiene, maximal barrier precautions, chlorhexidine skin antisepsis, optimal catheter site selection, and daily review of line necessity. So hand hygiene. So 5 moments of hand hygiene should be adhered to. OSHA for prevention of blood-borne pathogen exposure to healthcare workers, gloves are required, and they advise must and should. And use of gloves do not obviate the need for hand hygiene. You need to do hand hygiene. So maximal barrier precautions for the provider would be hand hygiene, non-sterile cap covering all the hair, and mask covering nose and mouth tightly, sterile glove for the patient, covering the patient head to toe with a large sterile drape with a hole for insertion. And when adherence to aseptic techniques cannot be ensured, that is when catheters are inserted in an emergency, replace all the catheters as soon as possible or within 48 hours. Skin antisepsis with chlorhexidine gluconate 2% is recommended, and allow the skin antiseptic solution to dry for at least 2 minutes, and do not routinely use arterial venous cut down procedures. And if the patient is allergic to chlorhexidine, povidone iodine or 70% alcohol can be used. In conditions where it is contraindicated, like in meninges or children less than 2 months. So site selection, optimal site selection, subclavian when not contraindicated, preferred site. But the thing is, with subclavian risk benefit ratio, skill of the operator and of the person doing the procedure, and complications such as pneumothorax, subclavian artery puncture, all those things should be taken into mind. Phlebitis also long recognized as a site risk for infection. So lower extremities, that's why are avoided because they have higher risk when compared to upper extremities for developing phlebitis. And even in upper extremities, cannulation in the hand is poses lesser risk than the forearm and arm for phlebitis. And highly contaminated areas should be avoided, like femoral areas, and daily review of line necessity should be done. And many times they are simply left in place central lines because they provide a reliable access and the personnel have not considered removing them. So daily line removal or necessity should be included in your discipline rounds and sheets. So impregnated catheters are also available. Chlorhexidine and sulfur sulfatazine impregnated catheters are also available, and they significantly reduce and CA-BSI risk and give us benefit, and cost effective also if you in the long term, because you'll be cutting down on antibiotic use. And cleaning the rub the hub with 70% alcohol should be done, and all the stopcock should be clapped when not in use. In catheter site dressing, so every at least weekly for adults, or when it is obviously soiled, damp, or for inspection. And usually sterile, transparent, semi-permeable material is used. Topical antibiotics and creams should not be used as they will lead to colonization with antimicrobial resistant pathogens or flare of fungal infections. And replacement of the catheters. So whenever they are inserted under non-aseptic technique, they should be replaced as soon as possible or within 48 hours. And do not routinely replace CVCs, PICC lines. Use clinical judgments. Even when there is a fungi or bacteremia, if source of the infection is unlikely to be the catheter, then catheter replacement is not warranted. So proper selection of site, maintenance, insertion, and maintenance should be done. So routine replacements or guidewire exchanges are not recommended. And how a catheter CVC is removed, because CVC removal usually exposes a patient to air embolism. So patient should be flat with or head end should be slightly down. That is a slight Dunderberg position. Instruct the patient to take a deep breath in and pull the catheter out during exhalation. Apply firm pressure for adequate time. So this is how a central line insertion checklist will look like. Patient identification details, site of procedure, and other details and areas, site, technique, person doing the procedure are recorded. And critical steps before, during, and after procedure would be: before the procedure, education of the patient, taking consent, selection of the site, marking of the site, for a patient positioning, then antiseptic solution application over the procedure, draping, and maximal barrier precautions there should be adhered to. And then during the procedure, venous confirmation of venous placement prior to dilatation, and blood aspirated from each lumen or not. Then flush, clamp, cap all the lumens. Then proper dressing with cleaning of the blood after the procedure. So checking the dressing, then confirming position with axillary fluoroscopy, then usage. So if femoral line is placed, then early resighting should be advised. And then post procedure, noting down the events during the procedure, whether antiseptic precautions were adhered to or not, and then monitoring after the procedure. These form your central line checklist. These should maintain in your case sheets. Now we will come to the catheter-associated urinary tract infections, CAUTI. So UTI is an infection involving any part of the urinary system, including your urethra, bladder, ureters, and kidney. When it is associated with an indwelling urinary catheter, it is labeled as a CAUTI. So, fifth most common type of hospital-acquired infection, as you know, morbidity, mortality, length of stay, cost increases, unnecessary antimicrobial use it leads to. So, CAUTI. So, urinary catheter use. So, 12 to 16% of our hospitalized patients have a urinary catheter. So, most of the times they are placed for inappropriate indications, and our physicians themselves are unaware whether the patient is catheterized or not. When in rounds we ask whether the patient has polyps, they will search around the bedside. So, more than 50% did not monitor which patient is catheterized, and in a survey, more than 75% did not monitor whether the patient is necessity of the indwelling catheter, whether it is required for the patient or not. So extraluminal, intraluminal sources for CAUTI are available, are there as described in the picture. Intraluminal would be break in closed drainage system, contamination of the collecting bag. Extraluminal will be early during the time of insertion, not related to the sterile procedure, aseptic techniques, and late by capillary reaction. Then they can form a biofilm that will give them resistance to antimicrobials and host defenses. So core preventive strategies would be insert catheters only when it is indicated and remove only as soon as possible. Ensure that only trained pro people insert the catheter and aseptic techniques are made there too, and daily proper training of our healthcare system is done for proper maintenance and monitoring of your urinary tract, indwelling urinary tract catheter. So maintain a closed drainage system, unobstructed urinary flow should be there. So first part would be anyway hand hygiene. Second would be maintain a closed system. If breaks in aseptic technique or disconnection or leakage occur, replace under aseptic techniques with a new catheter. Consider using urinary catheters with pre-connected urometers. They are available these days. So only when clinically indicated, pre-connected urometers are preferable. And if patient requires single irrigation, change the entire system after consider inserting a 3V. So maintain the bag below the level of the bladder as shown in the picture to maintain an unobstructed urine flow and ensure that the bag is emptied prior to transport or when it is 2/3 filled. Use a catheter securement device to anchor the catheter. Keep the urine bag off the flow. So strategies to maintain unobstructed flow. Incorporate observation of urinary catheter bag into your routine rounds. So perform a simple checklist. Catheter secured or not and drain bag empty or not. So meatal cleaning, soap and water is best and not antiseptic solutions. So inspect meatus daily for redness, irritation, drainage. Assess catheter where it enters the meatus for encrusted material, remove them and do soap and water cleaning during your daily bath and remove any encrusted tubing from encrusted material from the Foley's tubing and ensure that Foley's tube does not go in out of the catheter during your cleaning. Supplemental strategies would be alternatives to indwelling catheters like nail cap, portable ultrasound devices to reduce invasive catheterizations, antimicrobial or antiseptic coated catheters. So healthcare staff responsibilities in preventing CAUTI will be hydration, emptying drain bag once it is 2/3 filled, avoid cross-contamination, isolate the urine drainage bag when patient has multiple drainages like abdominal drains. Keep the drainage bag below the level of the bladder, maintain an unobstructed flow, maintain closed system, maintain hand hygiene, maintain a bundle. Patient should be educated regarding the Foley's care. So a bladder bundle would be aseptic insertion, proper maintenance, dependent drainage, catheter, whether it is required or not, daily assessment, and switching to a non-invasive ways like condom catheter or assessing ultrasound wells. Strategies not recommended for CAUTI prevention would be so changing the catheter at routine fixed intervals is not recommended. Routine antimicrobial prophylaxis is not required, and cleaning of the periurethral area with, as we discussed, antiseptic solution is not required. Is not recommended. And irrigation of the bladder or drainage system with antimicrobials or antiseptic solution should not be done. And routine screening for asymptomatic bacteriuria is not recommended. And this is the algorithm. Some key points should be always use smallest appropriate indwelling urinary catheter and leptin assistance when required, like 2% insertion method. And do not pre-inflate the balloon prior to test the balloon prior to insertion. It is not recommended. And when do you inflate the balloon? After you have inserted up to the Y junction in the males and in females. Once you get the urine flow, 1 inch or 2.5 centimeters further, you push the catheter in and then inflate the balloon. How much should be balloon be inflated? Around 10 ml. Now we'll come to our other aspect, ventilator associated pneumonia. So hospital acquired pneumonias are pneumonia occurring in a patient 48 hours or more after admission. So VAP would be type of HAP developing more than 48 hours after intubation. That is pneumonia occurring 48 hours or more after intubation with increased purulent tracheal secretions, new infiltrates on imaging, or patient having worsening oxygenation status with fevers, hypothermia or leukocytosis. So what are the ways by which VAP can occur? Healthcare professional transmission through the healthcare professional handling of the system and feeding tubes aspiration of the GA3 flora from respiratory tract, ventilated devices, humidifiers, fecal oral migration. So, implementation of the VAP bundle. What constitutes a VAP bundle? Proper hand hygiene, oral care, subglottic suctioning, head up, bed up, that is semi-recumbent position, 30 degrees or more, and when not contraindicated, endotracheal tube rotation daily, GI prophylaxis, nursing documentation. So, 8 elements of the VAP bundle. So, subglottic suction, endotracheal tube should be used when you are anticipating a patient to be mechanical ventilator for more than 72 hours. Always prefer orotracheal insertion and cuff pressure should be maintained between 20 to 30 centimeter water and measured every 4 to 6 hourly or before and after mobilization. Daily sedation hold should be unless contraindicated be done. So nursing in a semi-recumbent position, ventilator tubing and suction should be only changed if indicated or every 1 week. Stress ulcer prophylaxis, judicious use should be done for GA bleed risk prophylaxis. So if a patient is on enteral feeds and there are no other risk and there are no risk factors for GA bleed, it is not recommended for the patient to be on stress ulcer prophylaxis. So regular oral hygiene should be given. So prevent colonization by avoiding a nasotracheal intubation or nasogastric tubes, oral care decontamination, secretion clearance, stress ulcer prophylaxis. Prevent aspiration by head up, adequate cuff pressure, subglottic suction, avoid unplanned extubation, reintubation, avoid gastric overdistension. So use sterile water to rinse, reusable respiratory equipment, remove condensate from ventilator circuit, and when you're doing that, keep the ventilator circuit closed. Change the ventilator circuit only when visibly soiled or malfunctioning. Store and disinfect the respiratory therapy equipment proper. So minimize duration of ventilator. How do we do that? When we usually give a spontaneous awakening trial when not contraindicated. Patient passes that. We do a SBT. Patient passes that. We'll try to extubate to early extubation to NIV or tracheostomy. Points to note are: so support the endotracheal tube and connecting tubing as required, as needed. This should not be dragging down. And intubated patients should receive oral care after intubation, admission to your ICU, and 4th hourly and as required. Provide suctioning as suctioning should be done. How the suctioning should be done? First, always do a endotracheal tube suctioning, then do a subglottic and oral suction. So the endotracheal tube suction should be done first, then only subglottic and oropharyngeal suction should be done. And prior to moving the patient or transporting the patient also, suction should be done. And subglottic suctioning should be performed every 8th to 12th hour. Endotracheal tube rotation should be done every 24th hour. These points you should note. So thank you. Thank you for this opportunity, ISCCM Hyderabad chapter. I hope the message is received.